Could you give me the share thing?
I think you've sent it to me, Jeff.
Oh, sorry. Let's try this again. There we go.
All right. So this is a patient who presented with cough and shortness of breath. I read a follow-up chest x-ray that looked similar, but one thing I want to kind of tout is, although it's by no means perfect, Albert Chow and his group kind of developed a nice AI algorithm. To me, this is pretty conspicuously abnormal, but we have some general or non-chest people trained reading overnight or after hours, and this was read as actual just some mild bronchial wall thickening. Here's the AI that Albert developed picking up this abnormality quite well. Anyways, this patient, I called the ED because she had this finding for about 2 weeks, or about 10 days. And they said, well, she had an house, and I said, it really looks like something on chest x-ray. And I looked at her history and I'm like, this fits pretty perfectly. And of course, everything is rule out COVID. She underwent 2 tests for COVID, both of which are negative. She is febrile and has a white count, but the white count that she's not, she doesn't have any shift in anything. And you can see here, it's mostly ground glass, a lot of it peripheral, some subpleural sparing, a lot of crazy paving. And let me do this real quick. Let me pull over, I meant to do this quicker, pull over her history. So here's her history. She vapes, but she started really vaping heavily because it's been raining and she's been stuck inside because of the rain. So she decided to vape a lot more. So she's vaping intermittently, but states she's been vaping daily for 2 weeks because of the rain. And since she started vaping, it corresponds with her symptoms and her shortness of breath and her fever. So a presumed case of a EVALI in the pandemic world of COVID. And of course, the imaging findings are similar in many respects, especially given the fact that this is probably 2 weeks after the onset of injury. But
did she say what she was vaping?
Both marijuana and tobacco.
Okay.
But she swears that it's legitimate because her cousin who gave it to her got it from a store. So that's what the ED doc told me when I called him. I said, on the chest x-ray, look in the history, this has got to be EVALI. He's like, oh, really? I'm like, yeah. I was like, okay.
Yeah, I just had a case the other day that was, looked like it was a COVID rule out, and it ruled out, and, the patient had an acute lung injury and is getting better. But it also was vaping, and similar thing. The patient was vaping more, partially because they're sitting at home because they're, not working.
Right. Yeah, exactly.
While the rest of us are drinking more, they're vaping more.
Yeah. No, but this is actually the second case of EVALI I've seen in the last 3 weeks. I mean, I hadn't seen one since probably January.
Yeah, like we talked about, right?
Like January.
CDC lost interest in February.
Yeah, and then people just, like you said, stuck at home, not doing anything, and just vaping all day. So
yeah, it'd be interesting.
So, Jeff,
say it'd be interesting. Yeah.
Go ahead.
Okay. It'd be interesting to know how many of the, the rule out COVID-19s that show this kind of pattern, end up being vaping. Now that, flu is, I wonder how many are just going undiagnosed.
Well, when your comment you made just a couple minutes ago with your patient that ruled out for COVID, how are you guys considering patients ruled out at this point if they're symptomatic? Is it 3 negative PCRs or what?
I don't think we have a standard. I know we had a couple they've done 2 on, spaced out fairly, not just a day, but like 6 days apart. And they're getting better. So, I don't know. If you're getting good samples, we're doing it all in-house, and it's, It's not the point of
Yeah.
care one, which is not apparently not as accurate. But interesting. Our head of pathology was sort of giving us a little mini in-service during our department meeting the other day, and he was saying that seems to be a time frame where the test, as we know early on, it's not as sensitive, but even later on, it may not be as sensitive in the nasopharynx anymore. So, and so different stages of the disease, maybe, BAL, sputum, are more accurate or have a better viral load in them than a nasopharyngeal swab. So I don't know.
Yeah, no, if we're low clinical suspicion, I think it's 2. And we had a case, and we still have a case. I mean, I don't know if I might have showed it last week. I can't remember, but a prison guard who came in, a lot of exposures, very classic COVID look, treated, got 3 negative tests 2 days apart, and then put into the inpatient. Then he underwent a bronch and had a negative test. And
Okay.
I mean, that one it was such a high clinical suspicion, but everything came back negative. And then they started really ramping up his antibiotics, and he started doing dramatically better, even though the imaging looked pretty viral.
Because that's, I mean, I think 3 should be sufficient, especially if the clinical suspicion isn't that high. And a lot of the naysayers will say you have to do a bronch, because there's some of that data from Italy in particular where they showed the PCR was positive only on bronch. But and this was only guy, like, they were just like, it has to be, and for us, it really is like 2 is kind of the someone coming in with cough and malaise and maybe a low-grade fever, they'll do 2, but someone coming in with dramatically abnormal imaging and that fits, usually 3. But I don't think there's a guideline. And this is a case, it's just a pretty case. It's just something, it's the only second time I've ever seen this, not the high origin of the RCA, which is cute. I took a picture of this. I emailed this or texted this, I think, to Travis the other day. I just haven't seen one in many years, where you get the nice quadricuspid valve, the 4-leaf clover, and it's a pretty fixed aortic regurg. So he came in because of but decreasing LV function. And as you can see, the LV, if I go along the plane of the heart in some logical manner here, you'll see that the LV is not super happy. It's dilated. I mean, this isn't even end diastole, and you can see that. I mean, I don't know what measurement, people use different measurements, 5 millimeter or 5 centimeters, 6 centimeters. I never even measured it, but it's just big. And so this guy has chronic AI due to his quadricuspid valve, and I don't know, just a pretty case. And
is the usual abnormality regurg as opposed to stenosis?
Yeah, most of them I've seen, most of them I've seen 2, and both of them had regurg. And the other one was actually, and most of these are, believe it or not, are incidental. This reading up on them, from my understanding, bicuspids get into a lot bigger issues than these guys do. First of all, this is just dramatically rare. But most of the ones I've seen, either in books or other things, it's just mild regurg. It's not like the unicuspid valve, which is usually associated with dramatic abnormalities elsewhere, and those patients present quite early. These are usually symptomatic or mildly symptomatic. But I may be wrong, but that's my understanding. And this is just a nice, pretty case. Nothing, what I like about this is the expiratory imaging on this. So this was a patient, I'm not sure, a lot of these patients come in and they get non-contrast CTs, and because they have shortness of breath, so they get a non-con CT. The non-con CT shows mosaicism, so then they undergo a expiratory protocol. But just to show you, this was not, clearly not a case of airways-induced mosaicism. But what I like about, then here you can see the mosaic attenuation throughout the lungs. Due to this case of CTEPH, quite a big right heart. What I like about this was first of all, I I got to get our guys to develop this protocol, because I really like this protocol, this expiratory protocol. But let me move this over here. So this is the expiratory phase that an outside place does, where they clearly just do a limited, maybe one slice kind of multi-phase expiratory view. And what you can see here is that you can see the mosaicism, and it's just a nice teaching point that you know, even though there's areas in it, and something that I'm still trying to kind of teach my younger guys, that even though the mosaicism persists on expiratory imaging, the areas of lucency are getting denser on expiration. So they're not staying the same attenuation on inspiration and expiration. So, you know, it's not just that still perceived difference in attenuation on inspiration and expiration that defines air trapping. It really is the lack of change within the affected segments or lobules or lobes, whatever. Because a lot of people want to say, well, it's still, you can still see the difference, it's still bright. Well, yeah, there's still going to be vascular pruning and, you know, secondary related to hypoxic vasoconstriction and all that stuff, and shunting of blood away to other areas, but the airways are still open. So you shouldn't really get the air trapping. So this is just a nice, but there are reports, if you look at the original reports that were done about 20-something years ago now, they describe that some people with CTEPH do have some air trapping on expiration, but that's never been really tested in a live or large population. I just thought a nice expiratory view showing the difference between air trapping from small airways disease versus mosaicism from vascular perfusion abnormalities.
Excellent. So, all right.
That's it.
All right. Well, let me just show one little case here. If there's time, I've got some more. So this is a, I forget how, 50-something-year-old who has a history of repaired tetralogy of fallot. Has a couple of interesting findings. First, you can see there's probably some tracheal malacia, or at least some mix of EDAC and malacia. This is expiratory, and you can see the trachea is quite, the cartilage is splayed, and there's quite a bit of narrowing at the aorta there. Patients had multiple surgeries, so maybe that's all related to multiple intubations or something like that. But it has a kind of interesting anatomy. That's why I'm going to show the case. I'm curious. So one of the fun things is you can see there's an absent left brachiocephalic vein, and what actually it does is it's almost a persistent left SVC, but it dives under the aorta and plugs into the SVC. So it's a subaortic brachiocephalic vein, which are pretty uncommon, but this one takes a funny, so kind of a little bit of a funnier course there. And then you can see the patient had some branch pulmonary stenosis and has a stent in here, and the stent's open, but you can see the marked difference in the right and left pulmonary artery. And then there's even some preferential flow to the different lungs, the two lungs here. You can see just how different the pulmonary arteries are. And if you go down to the periphery, the left lung, I think part of it's the left lung may just be hypoplastic, and that may have something to do with the pulmonic stenosis that was there, presumably at birth. And you can see just there's a lot larger vessels. Now, there's not a lot of difference if you go to the lung windows, and it's a lot of motion there, but it doesn't look like a marked difference in attenuation. But not surprising, just given how small that left pulmonary artery is, even with the stent, that most of the blood flow is going to the right lung. And then if you just look at the lung size, I think there's some hypoplasia of the left, probably from pulmonic stenosis. So I don't know. We've seen a few isolated subaortic brachiocephalic veins, but the ones I've seen mostly are in the cases of TET. I don't know if anyone else has any experience with that.
It's my favorite venous anomaly. I see it maybe once a year. Actually, I haven't really seen it associated. I mean, I'm sure it is. I usually just see it in random people, but
yeah,
it's acute. Yeah, it's always
been a couple of years since we've had one on here.
Yeah, I'm always looking for them, and then this one came across. This patient was referred for pulmonary hypertension, and that's how I came across the case. The pulmonologist was interested in not the vein, but the asymmetry. But I think probably that's what's happened, is that this lung is hypoplastic, and just started out that way because of the this branch pulmonary stenosis and just underdeveloped, like we see with interruption of the pulmonary artery where you get a hypoplastic lung, but it's usually very abnormal. In this case, it's just normal. And then I think the malacia is unrelated to anything, but maybe multiple surgeries or this aorta sitting right there. Okay, I have got more if there's time, but we have a lot of people on, so.
Jeff, I have a couple.
All right, let me go back to our list. There we go. All right, David, you should have control of the screen.
So based on our discussion last week where there was a couple of aorta cases and the diagnosis of syphilitic aortitis came up, I wanted to show you some ancient cases that I've had digitized. And I think, Jeff, that you helped process these images here back in 2009. Could that be true? Because
well,
except
I graduated in 2005.
No, but were you having the Caney conference?
I was.
Back in, yeah. Well, these might have been shown back then. I don't have them on my list of recent showings, but anyway, this is what syphilitic aortitis is supposed to look like. It's really an intense atherosclerosis of the ascending aorta. So you expect to see calcification, as we do in this case on these wretched ancient plain films here. But we definitely have an aneurysm. And let me show you, should be some more images here. Okay, here's the lateral view with this tremendous dilation of the ascending aorta, and once again it's calcified, so it's a very large lesion. And then here's the angiogram that shows again this tremendous degree of dilation. Okay, I'm having a little trouble here advancing images. There's the lateral view. Okay, so let me show you another case. Again, it's an ascending aortic process with heavy atherosclerosis. So the pathologists describe this as tree bark. The intima is just rough and it's often very calcified, as in this case. This one doesn't have an angiogram, but it does have that very nice ascending aortic calcified aneurysm. And one of the characteristics of this is that sometimes the aneurysm will extend into the right brachiocephalic artery. So it's proximal. Atherosclerosis prefers the arch and descending aorta and the abdominal aorta. Atherosclerosis in the ascending aorta. In the Charlie Higgins days of the 70s, when he wrote about this, said that if you see calcification of the ascending aorta, a quarter of the cases or a third of the cases, I can't remember which of those two it was, would be syphilitic rather than atherosclerotic. So ascending aortic calcification should raise the question of syphilitic aortitis. And here's another case, again, with a tremendous aneurysm of the ascending aorta, calcification in its wall, and a fairly, normal looking descending aorta going down. So it's because of this distribution that I was a little skeptical of the diagnosis of syphilitic aortitis for one of those other cases. And I wanted, one of these has a head CT, and Jeff, if I get into having some visible patient information, can you remove it?
Yeah, I can.
Okay. There was one of these cases that I should be able to display an enhanced head CT. So this is a contrasted CT. The non-contrast study looked fairly normal, but we have this sulcal enhancement here. So this brightness here evidently was attributed to the neurosyphilis component of this disease. So syphilitic aortitis, classically ascending aortic involvement, heavy atherosclerosis, calcified, dilated ascending aorta, may extend into brachiocephalic artery. And so it's a different distribution from cases shown, I think, last week. So these are my ancient cases. You can see the yellow cast to them. The yellowness is a sign that you may be dealing with syphilis. Now, in the old days of film, if you had a yellow film, you were supposed to think of syphilis on the boards. So I just passed that on. Not that it's very valuable these days.
Yeah.
Okay.
The other clue, David, was if especially it was an abdominal radiograph, if you saw mercury in the soft tissues of the of the
Right. Yeah, of the buttock.
flank or wherever. It was syphilis as well.
Right, got it. Okay,
All right.
thank you.
Who's next?
I've got 2 cases, Jeff.
All righty. There you go.
Okay, these are 2 pleural cases. Let me start with this one. I'll show this one in reverse order. So this is recent, and the finding here is very extensive pleural disease. Not only do we have pleural fluid, of course, we also have pleural thickening, and I'll scroll through that to show you the extent of it. Here is pleural thickening over there, for example, but there's pleural thickening very diffusely. Of course, in some areas, there are foci of atelectasis, contiguous with the pleural surface. And one thing that this shows, here you can see not only thickening of the visceral pleura, parietal pleura, that when you have chronic pleural disease and areas of atelectasis form, so-called rounded atelectasis, you don't have to have fusion or symphysis of the visceral and parietal pleural surfaces where the areas of atelectasis form. I've seen that for sure, maybe a couple times with chronic hepatic hydrothorax. We have chronic pleural fluid, but you don't have necessarily fusion of the parietal and visceral pleura. So here you can see areas of atelectasis forming in multiple locations. And this has been going on for a long time now. So this is before the patient had transplantation for a fibrotic lung disorder. But this has been going on for quite a long time. So you can see pleural thickening. This is in June of 2018, certainly on the right side, but some also on the left. And I'll show you just one more from, say, 2019. This is March, showing you extensive pleural thickening. So I think this may be the most chronic and extensive pleural disease I've seen in the context of lung transplantation. You can see he had a Pleurex catheter for that. I don't know why this forms. This has been a lymphocytic pleuritis, exudative. Here you can see a biopsy of it, no malignancy. Have any of you seen such a chronic and extensive pleuritis in the context of lung transplantation? We see pleural fluid not uncommonly, of course. But this one is really striking.
Yeah, not that much. I mean, I see pleural thickening in almost every patient afterwards. But yeah, you're right. And you know, we have seen in lung transplant patients sort of the pleural parenchymal fibroelastosis, but not, you know, more in the upper zones and involving lung. This looks, yeah.
This seems to be just pleural, right?
Yeah,
it is just pleural, pretty much.
I wonder,
Rather
yeah,
impressive.
an unusual form of rejection or something, or
No idea.
yeah.
I've tried to search for case reports of chronic serositis, pleuritis, lung transplantation. I didn't find any on a relatively brief search of that. And I don't think I've seen that before, so extensive. So don't know what to make of it, but there you are. This one is even a more interesting case of an entity that I'd never heard about. But this patient has, as I'll show you in a moment, chronic pleuritis, serositis, and I will show you that, and I'll show you on another instance, but here's the time back in May of 2019 when he has large pleural effusions. I don't see any pleural thickening, just pleural fluid, but rather impressive at that time. Let's go forward to June of last year again. And you'll see the same thing, except he also has pericarditis. So he's got a serositis involving his pleural surface and his pericardial surface. And what this person also has, and it's been rather persistent, is chronic soft tissue edema, and it's generalized. So a combination of chronic extravascular, extracellular water and pleural effusions and serositis. He's had that drained multiple times because these effusions are quite large. Here is a recent chest radiograph from last month showing you how much pleural fluid he has. And of course, we know that a good portion of this is the persistent generalized subcutaneous soft tissue edema. So unfortunately, this has been a really chronic problem for this person. And here is the entity that I didn't know about, but here's a case report from 2005. So this is called a vascular leak or capillary leak syndrome and serositis as an unusual manifestation of chronic GVHD. And he does have that. He's had allo stem cell transplantation for AML. This goes back a time, and they treated that with steroids, but he's got this persistent entity. And the kind of theories about why they get that, they think it may be related to chronic production of cytokines, some immune-related phenomenon, but the consequence is capillary leak. And he has both the pericardial, and the generalized soft tissue edema. And if I've ever seen this before, I've never been able to diagnose it. I wouldn't have, because I just didn't know about this entity that is described in this article. So if you want to read more about it, there's the reference for you. Have any of you heard about that or perhaps seen that before?
I have not.
No.
No, neither have I.
So is the capillary, the vascular leak is separate from the serositis? Because it looks like they're listing this as two different things. Because I've seen chronic serositis a couple of times, but not the subcutaneous edema and the other things you're describing.
Yeah, I think it's all thought to be somehow mediated by something that makes capillaries leaky, but it's interesting that it involves mesothelium, seemingly, right? So I'm not sure the connection between the serositis and the leaky capillaries as such, but they seem to potentially go together in the same patient, right? So.
And is it a sterile exudative fluid? If you said, I missed it.
I think it is a transudative rather than exudative, but okay. I would have to look at that. Let's see if I have information about that in my history. I don't have that information directly. I would have to look.
Very nice case.
Yeah, so something quite curious, and I definitely had never heard of that before. Just saw this case the other day, and by chance looked at the medical record and began to read some more. So been going on for some years now. All right, Jeff, those are my two for this week.
Thank you. They're both very interesting. All right.
I can show a couple here.
Sure.
All right, see a chest radiograph?
Mm-hmm.
Yep.
Yeah, so this is a patient that came in last week and fever, some abdominal complaints. It's a low-grade fever. So of course the suspicion is COVID. They had a leukocytosis rather than a decreased white cell count. And you can see the radiograph is abnormal. So certainly findings that would fit with COVID infection or pneumonia. There's kind of subtle opacities, both lungs. So it gets admitted. PCR ×1 is negative, clinically doing worse, radiograph doing worse. PCR ×2 is negative, still doing worse. And you can see this now looks a little bit more, it's diffuse, but it's kind of more central and a little bit of sparing of the subpleural regions. PCR ×3 is negative, and then they finally do a CT. And this is a guy in his 30s. And credit goes to one of the ICU pulmonologists who was actually wondering if this could be something other than COVID, especially at this point. And I did not coordinate with Seth to show this case today, but it turns out that he has also been vaping marijuana or THC products. So not sure how much his pattern, his habits have changed, but to me, this looks like a pretty slam dunk case of EVALI. It has several of the features that we saw, that Seth so nicely described in the past, like the sparing along these bronchovascular bundles, some of the septal thickening. And then as you look in the upper lobes in particular, I have yet to see a case of COVID that had more discrete centrilobular nodules as this one does. I mean, this looks like that airway-centered organizing pneumonia that was proven in so many of those cases of EVALI. So this is why I asked the question, at what point do you consider them negative? I think there's such an anchoring bias on the part of some of the clinicians that they were really reluctant to start steroids even after this CT because they're still worried about, coronavirus. But they finally did start steroids a couple days ago. I don't know if the patient's doing better yet. I suspect they will be at some point, but I think this is the first one I've seen in a few months. Has anyone seen, David, you've probably seen the most COVID in practice. Have you seen any that have any, the more of the centrilobular nodules as we see in these with the more airway-centered injury?
No, I have not.
And it's not being reported in the literature either.
No. So I think this one, I think this is a good utility of CT in the COVID era. This is a good problem solver. And in this case, when you have multiple negative tests, but a radiograph that looks convincing, I think the CT is helpful in a case like this. And there are small effusions as well.
Yeah. Does he have any soft tissue edema? Can we potentially blame the lung edema on fluid overload, or maybe we can? No, not particularly.
No, good question. A little bit,
yeah.
A little bit of renal sweat, and he's got a really thick diaphragm there. But yeah, so
show me his pectoral muscle. I think the guy lifts weights.
Yep.
Yeah. So sounds like a San Francisco kind of guy.
That's right. This is one I sent a couple of the delayed enhanced images to some people recently, because it's one of the more impressive cases I've seen in a while. 21-year-old woman who reportedly has a history of prior myocarditis times at least 2, had a prior right heart cath and biopsy that was negative, came back into our ED for the first time with chest pain. And you can see that her left ventricle, she has mild global hypokinesis here. Ejection fraction was somewhere around 40%. When she was transferred in from the outside hospital, they had reported it at 30% at the time she came in. And this is one of those ones that my resident or fellow who was scan checking this, saw these delayed enhanced images and thought there must be something wrong. I think it's because we rarely get images of this striking quality, but B, this amount of enhancement. And I'll window it so you can see. You can still see the subendocardium, and this is about as bad of or as pronounced of delayed enhancement I've seen in a nearly circumferential subepicardial distribution. And so this is, her troponin was off the charts. It had exceeded the upper bounds of normal, which is like 440. And that was at the time of admission to our hospital. She has elevated inflammatory markers, but the problem is we don't know the cause yet. And you can see it's a nice look for myocarditis. There's no family history. Giant cell myocarditis is particularly fulminant one, but I've never heard of recurrent giant cell myocarditis. And just curious, A, how often people have seen delayed enhancement this pronounced, and B, if you have any like specific entities you would think about.
Are there any bad habits that can lead to this sort of thing? Any drugs that could do this?
No, I mean, I've seen some
Not that I know of.
interleukin-2 medical drugs cause some pretty awful myocarditis, but not. I mean, this is just kind of crazy. Yeah, I've not seen that much enhancement ever. You know, the interesting thing is the conspicuous. It'd be interesting to see if you can show the RV.
Yeah.
Because, you know, there is RV involvement.
Yeah, there may be a little. Yeah.
Yeah, but look on the. Keep going.
Yeah.
I mean, I think there is RV
I think
involved, and
yeah.
to me, that usually points more towards right there, myocarditis than sarcoid, but both can cause RV enhancement as well. So, and there's no bulky adenopathy. I mean, it's got to be myocarditis. What the cause is, who knows?
Right.
Travis,
Exactly.
did you have a T2? T2?
No, we
images?
didn't. No, I mean, the best I can do is try and this scanner, we did not do any T2. You know, there's probably some heterogeneity, some subepicardial edema.
Is this a post-con or pre-con SSFP? Do them after
This
con?
is pre-con.
It's a pre-con.
Yeah. So, yeah, we're just left with crazy amount of enhancement.
Yeah, definitely.
So, and Seth, you had made the point the other day too that you've never seen a troponin this high with sarcoid as well, right?
I don't like. Sometimes you get some big ass granulomas that can as a bump. Sarcoid, you're traditionally thinking about, you know, conduction abnormalities. That's the classic sarcoid thing.
Which she doesn't have. Yeah.
This is pretty intense. I mean, I've seen some things half as impressive in this with sarcoid or myocarditis. I mean, this is really crazy.
Yeah. So, okay, Jeff, I've got one more, but I'm happy to hand off to someone else.
We have
we've got other people.
20 minutes, and I see Peter's on. So if you want to show your last case, then we'll turn it over to.
Okay, this is really quick. This is one of our COVID success stories. This is a patient was in the hospital since mid-March, and you can see was intubated at the time, multifocal consolidation. It looks like lung injury, remained intubated. He got extubated after a few weeks, really reduced lung volumes, just kind of coarse bilateral opacities. Once he was extubated, they did a CT. He was still somewhat dyspneic. It's a PE protocol. And this is after like 3 weeks in the hospital. There's no PE, but I will just show you, I think it's a good example of just old diffuse alveolar damage / ARDS. You can see there's anterior ground glass, just coarse reticulation, some architectural distortion, some areas of traction, and the lower lobes are relatively spared. So I think this is, you know, a good look for just old DAD of any cause.
Yes.
And there was
right in the
so
organizing phase, presumably.
Yeah.
And, yep.
Yeah, and he had some little bit of secretions in his trachea and stuff. I mean, he's still in the hospital and rehabbing, but this is, I'm sure we're going to see a lot of this from the patients that do survive. So,
Travis, how long was he on a ventilator?
several weeks.
Weeks on a ventilator. You know, they must be, you know, there's been this stuff coming out recently about how you have to modify the ventilation stuff. These people have the unusual combination of being hypoxemic, but having normal carbon dioxide levels, and sometimes sitting there comfortably talking on the phone, but their oxygen tension is like 40. So they tolerate, you know, a lot of hypoxia here, and they may be shunting through, I figure that must be shunting through areas of consolidation that would normally be vaso-regulated down so they wouldn't be perfusing unoxygenated parts of the lung. But there's been emphasis on how ventilators may actually make this condition worse. So you have to do volume support, but not pressure support. You don't want to over distend the alveoli that are working, proning the patient, and all those other maneuvers they learned in the ICU are very helpful in this condition. And they're trying to keep a lot of people off of ventilators because they seem to make things worse in some of COVID cases. So your guys must have been very judicious in their use of pressure, because he doesn't have the cystic abnormality that goes with being on a ventilator for that long, you know, where the lung just blows out these holes.
Right.
So, you know, he probably is going to have a good recovery of a lot of lung.
How far after is the CT from his?
So this CT, he was admitted early, you know, over a month ago, and this CT was from basically 4 weeks after his admission.
But yeah, he'll have some. I mean, he'll still have some decent amount of scarring, but I think a lot of that we see here is going to get better. I don't know if that was what Dave was saying, or you know, I think a lot of this, it doesn't have as much volume loss and a lot of architectural distortion like a lot of these cases have. I think that lung there is going to stay pretty bad.
There's a little bit, yeah.
Yeah,
that's what I'm saying. It's more of the anterior and upper lobe stuff that's going to stay.
Yeah.
Yeah.
But I think if you scan them again in 3 months, they're going to look pretty good, or at least a lot better.
Yeah, he's clearly still dyspneic at this point since he can't hold his breath for this CT.
Right.
Yeah.
So, but okay.
All right. Peter, you got cases this week?
I just have one at
Okay.
this time.
No problem.
So this is just a case of a bicuspid aortic valve with some nice associated abnormalities. So this is just an axial view, and you can see the abnormal root, and this is a bicuspid aortic valve. You can see the bicuspid valve, no raphe here. And show these 3-chamber views here. So in this 3-chamber view is nice because you can see it's well aligned with the axis of the high velocity jet, and what you usually get on SSFP if there's good alignment is this central signal hyperintensity, and due to phase coherence, and then peripheral on the periphery of the jet there is low signal intensity there, and you can see kind of on this image there isn't really that good of alignment, and you just get the flow void. There's the jet. But the other thing to draw attention to is the myocardium, and so I'll just start off by showing the short axis synase. So here you guys can see the short axis of the synase from base to going to apex, and if you pay attention to the septum here, you can see there's relative akinesis at the base and mid levels of the septum, especially if you compare to the lateral wall, relative akinesis. And the other area, there's more subtle akinesis here, is this infralateral wall, and then it's going to show the delayed images. And so here are the delayed images, again, from base to septum, and you can see this patchy and focal late gadolinium enhancement, particularly in the region of the septum where there was wall motion and abnormality. More subtle changes are also noted here. So this was I thought, most consistent with myocardial fibrosis, secondary to as remodeling of the LV, secondary to long-standing aortic stenosis. This is a nice review article about this process, which is not very uncommon. But there's two basic patterns. The first is the early stage of interstitial fibrosis, which is reversible, and it's subclinical and it doesn't show up as late gadolinium enhancement. You can see it on T1 mapping. And then as this process progresses, you have replacement fibrosis and focal areas of replacement, which you can see with the late gadolinium enhancement, which are also non-reversible following aortic valve replacement and associated with much worse outcomes. So this is what this patient has from long-standing stenosis. And then also we did do T1 mapping on this patient. And show the here's the image on the left is the T1 mapping, and I picked a little ROI where it's just compared to the late gadolinium enhancement, focus on an area where there is no enhancement. You can see the T1 relaxation time here is 1100, which for our scanner is elevated. So it's also consistent. So this patient has a background of interstitial fibrosis, and then a lot of areas of replacement fibrosis, setting of aortic stenosis, bicuspid valve. That's all I got, guys.
All right, I can show maybe one or two more. All right, so this is sort of an interesting case. So this is a patient with pulmonary fibrosis, and you can see it's both subpleural and peribronchial, and there's a lot of heterogeneity of the lungs. So nice look for fibrotic HP, and that fit with the clinical appearance here. But what's interesting is actually the presence of these dense calcifications or ossifications in the lower lobes. So I don't have tissue, but the presumption is this is a great look for pulmonary ossification. And I think we have it's unusual to see this outside of UIP. So I don't know. I know, we've talked about this a lot. We've seen a lot of examples, but I don't recall off the top of my head ever seeing a case with this exuberant amount of ossification in a patient who didn't have a UIP pattern, but rather a fibrotic HP.
But it is UIP.
Yes. Okay. Fair enough. I knew what I was going to say. Probably histologically there is UIP, but let me rephrase that. I have not seen it with a UIP pattern on CT.
There you go. I think there's that nice paper, I can't remember where it came from, in radiology that looked at all the cases with this. And I think it was seen in a couple cases of other causes of UIP.
Right.
Definitely most common in IPF, but no, it's
I've seen it with NSIP patterns, and I've also seen it in people who had pneumonia, and they ended up with it. So I think anything that induces fibrosis, some of those fibroblasts may turn into osteoblasts. So I think the inflammation and the fibrosis is the key thing, and any cause of those can generate some ossification.
I think there's some papers out there that correctly say that if you see the ossification, it's more likely to be a UIP pattern, but it's not 100%. So okay, and then this last case is an interesting case, and I'll be curious what everyone thinks. So my colleague Chris Francois shared this with me. This is a patient with Parkes-Weber syndrome, which is really a rare syndrome associated with vascular malformations, and we'll come back to the chest. has a very large AVM in the upper extremity. It's been coil embolized. You can see all these crazy vessels here. So that's the primary manifestation of this disease. But what's more interesting, I think, is his, and for the sake of time, this was actually done as a dual energy study on one of our scanners using KV switching, but I'm more interested in just showing you what the lungs look like. So this was done, and if you look, I'll come down, you'll see his pulmonary vessels look a little bit large. And as we come down in the periphery, you'll notice that some of them sort of get bigger again and then sort of taper. And then if you watch in this right lower lobe, they get bigger again and they start to taper again. So sort of these like little, like almost fusiform dilation of the pulmonary arteries. And you see it on both sides. You see it on the left as well, like this one right here in the anterior basal segment. So I dug around the literature and I couldn't find really much, but I presume, and, we talked about this week in our conference, that this is probably a manifestation of this Parkes-Weber syndrome. It's just some abnormal vessel protoplasm that leads to this sort of fusiform dilation of them. I don't know if any of you ever seen, I've never, this is the only case I've come across of Parkes-Weber that at least I remember in the chest. So I don't know, has anybody else seen anything like this or heard of anything?
I've never heard of the disease.
Never
Is it the same Weber as Weber?
Yeah, this is Parkes. I'd heard of it before, probably because when I did some peds, that's probably where I came across it. But yeah, I'll show the MIPS here. I think you can see some of these vessels down here. It's kind of similar to what we see with portal hepatopulmonary syndrome, but they're not so telangiectatic and little tiny ones, but slightly larger vessels. But I don't know. I'm guessing they're somehow related. I do have the iodine map, which is kind of interesting. Let me show that here, Jonathan. MIP. But you can see there's this funny perfusion defect down there, and so that vessel sort of fizzles out. There was no clot or anything. So I'm wondering if if on the microscopic level, there's some abnormality in all of these tortuous vessels as well with this. But anyway, I'll dig around a little bit more and see if I can find anything, but it did not come across anything. It just talks about these complex, large AVMs, and his was in his upper extremity, as I showed. I don't have any reformats of it. You might see it on this coronal. Yeah, this is the iodine map, but they just coiled embolized that thing there. But anyway, I thought that was interesting. And
so, in my experience with this, this dilation of the pulmonary arteries that you're describing here occurs in 100%. You write this up as a series of less than 1 cases.
All right. And then I'll show this case. It's a good learning case, I think, for the audience. So this patient, was being followed up for all of these nodules, and you'll notice they almost form these pseudoplaques. They're not real pleural plaques. These are subpleural nodules, and they're in a nice perilymphatic distribution. You can see them around the veins and primarily on the costal pleura. And so this is a case of sarcoidosis. Interestingly, there were some necrotizing granulomata on biopsy, which has been described. One of our former pathologists said you don't exclude sarcoid when you see that. But I think the clincher for me, besides the nodule distribution, is this icing sugar or powdered sugar calcification in the mediastinal nodes. It's very symmetric, very typical.
Yeah.
I mean, I won't say it's pathognomonic, but it's 99% for sarcoid. I do have one histo case that did this, but that distribution with these nodules is pretty classic. It's just an unusual sarcoid in that it's almost all in the costal pleura, instead of along the bronchovascular bundles and along the fissures like we often see. And they're larger too. So I think these are conglomerate granulomata in the lymphatics of the lung.
I blanked. I was working on something. What does the axillary nodes do to?
Probably sarcoid.
Yeah, that's quite impressive. That too.
Yeah.
That's have you seen?
I have now a couple times now. Internal mammary, upper abdomen. The one
I've
thing
seen internal mammary. I've just never seen symmetric axillary out of.
I've got a couple cases now. I can dig them out, but yeah, the other thing you have to keep in mind, I guess, is there is a slightly increased risk of lymphoma in these patients. But you see these are just big nodes. They look like normal axillary nodes, just fat. But yeah,
he's not an HIV guy. I mean, I don't know.
Not that I know of. Yeah, I mean, I don't know if they're going to do any further workup, but it's a pretty good sarcoid appearance. Okay, and then just one last Wisconsin case. So this patient has this mass-like consolidation with cavitation, a bunch of satellite nodules around the airways, and this no effusion, and some lymph node enlargement, but nothing striking. So this is a pretty good necrotizing infection, and we've shown plenty of cases of blastomycosis, which this is. But what's kind of impressive is look, if you can tie this together if you're aware of extra pulmonary involvement, and you can see his clivus, or what should be a clivus here, is just gobbled up. And let me get some axial images. Yeah, exactly. Yeah, the lung stuff I've shown before, it's not any more exciting than usual. But this one has this sort of necrotic areas in the skull base area, going all the way up and just gobbling up the clivus. So, anytime you have skin or bone involvement of looks like TB, and then what looks like it could be TB too, but in our neck of the woods, we still have to think about blastomycosis, and this one's one of the worst I've seen for bone involvement.
Wow.
Wow, that's a young person.
Yeah, and there usually are young people because they're outside and out doing outdoor activities. I don't remember all the details. It's really hard to pinpoint where it comes from, but it's often associated with just being outside. If it ever warms up here enough for the ground to get warm. Okay, well, it's top of the hour, so
quick question from the audience.
That's a reason to vote for
the comment.
Yeah.
Quick question on my EVALI case. How I mentioned that there was the sparing along the bronchovascular bundles. I know we saw that a lot. Seth or Jeff, did you guys ever? Do we have an idea why that happens? Is it just kind of like milking along the lymphatics there, or what is?
Lymphatic drainage, but who knows?
Yeah.
That's my guess.
Yeah, I mean, it's certainly not a diagnostic, criterion. It's more just an interesting finding that we saw in a lot of them.
You see the same thing with you see the same thing with pulmonary hemorrhage and with metastatic ossification. For some reason, you get this sparing around the edge of the lobule, and I just wonder whether it's because it's a central lobular process. It's being deposited centrally and it's working its way out. Doesn't always get all the way to the periphery. That's my rationalization.
Okay. All right.
Cool.
Well, talk to everyone next week.
Thank you.
All right.
Thanks, everyone. Great case. Have a good weekend.